Coming to the next part, that is the clinicopathology of the viral hepatitis. So, once there is a viral hepatitis, it can manifest or it can go through different other phases. That is, an acute viral hepatitis, in most of the cases it will subside on its own, but in some conditions they can go for chronic hepatitis with or without cirrhosis, and in some conditions the insult can be or the injury can be so aggressive that it can go for something known as fulminant hepatitis. So, the acute hepatitis is again divided into 4 phases if it is a symptomatic infection. So, acute symptomatic hepatitis can be divided into 4 phases, that is the first phase is the phase of incubation period, which will differ depending upon the etiological agent. Then you have a pre-icteric and icteric symptomatic phases. Then the last phase is the phase of convalescence. What we have noticed is the individual is infective, that the individual has maximum infectivity during last days of asymptomatic phase and early symptomatic phase. So, that is the period during which the infectivity is very high. So, chronic hepatitis. So, chronic hepatitis is defined as a symptomatic, is defined with this following criteria. So, the person should be symptomatic with biochemical or serologic evidence of continuing hepatic disease for more than 6 months. So, chronic hepatitis, luckily it is not very common. A very small number of patients go for chronicity leading on to chronic hepatitis. They usually have the same clinical manifestations like fatigue, malaise, loss of appetite and bouts of jaundice. Along with that, they have other manifestations like spiderangiomas, palmar erythema, hepatomegaly with mild splenomegaly, with tenderness when you palpate in the hepatic area. So, they can manifest with hepatic tenderness and other hematological and biochemical alterations in the form of prolonged prothrombin time, hyperglobulinemia, hyperbilirubinemia and elevated ALP levels. So, coming to the next thing, that is the carrier state. So, carrier state generally for any organism is defined as, a carrier is defined as an individual who is harboring the organism but is not manifesting any symptoms, but at the same time is transmitting that organism to other individuals. So, in case of hepatitis, the individual who is harboring that virus may have no obvious liver disease, or he may have a non-progressive damage without any symptom or disability. So, even when you do a liver biopsy, so there will not be any significant changes. So, the commonest conditions where we get a carrier state is in hepatitis B and hepatitis C. We have something known as healthy carrier in hepatitis B infection, where the individual is without HBe antigen but with presence of anti-HBe. So, you have antibodies, but there has no HBe antigen, and when you estimate his aminotransferase levels, it will be normal and the HBV DNA will be very low or undetectable. So, these are the features that we come across in healthy carriers in case of hepatitis B viral infection. So, coming to the morphology of hepatitis. So, tissue alterations in different forms of hepatitis are very similar, but few histologic changes differ. So, just like we get to see these ground glass hepatocytes. So, ground glass appearance is very commonly seen in chronic HBV infection. So, that is described as ground glass hepatocytes, or because of the presence of diffuse granularity in the cytoplasm, it is defined as ground glass appearance. And in HCV infections, we have noticed there are lymphoid aggregates with good number of hepatocytes showing steatosis and a lot of areas showing cholestasis. Then in acute hepatitis we see something known as ballooning degeneration, where the cytoplasm looks empty and there are scattered eosinophilic remnants of organelles. So this is about ballooning degeneration, which is commonly seen in acute hepatitis. When there is a damage to the hepatocyte and there is a rupture of the hepatocyte membrane, the hepatocyte dies and there is focal loss. It may be, usually it will be focal in acute, but when the insult is not cleared, so it can go for diffuse hepatocyte necrosis. So once there is loss of hepatocytes, there is a collapse of the sinusoidal collagen. The reticulum framework, whatever was present, because of the death of these hepatocytes, it collapses. So once there is hepatocyte loss, what these macrophages do, they come at the site of this hepatocyte death, they engulf these debris, these cellular debris. And if it is a viral etiology for hepatitis, the cytotoxic T cells, they bring about apoptosis of the hepatocytes and they form apoptotic, and there are a lot of apoptotic bodies in the hepatic parenchyma, and again this apoptotic bodies are also cleared by a rapid encroachment of that particular area by these macrophages. So these apoptotic bodies are cleared within a very short span of time by this phagocytic activity of the macrophage. Then you have something known as bridging necrosis. Bridging necrosis is the confluence of areas of necrosis which appears as if the portal to portal areas or the central to central areas of individual lobules are connected by this confluent zones of necrosis. And at the same time, when there is inflammation, or when there is insult to the hepatic parenchyma, the Kupffer cells, they undergo hypertrophy and hyperplasia. So and they are usually laden with lipofuscin. So they have this phagocytic, because they are macrophage and they have this phagocytic activity, or they have this nature to phagocytose. So they engulf a lot of lipofuscin pigment which are present in this hepatocellular debris. And you can have something known as interface hepatitis, where the inflammatory infiltrate which was present in the portal triad area, so it will spill over into the adjacent parenchyma, causing apoptosis of the periportal hepatocyte, which is known as interface hepatitis. And there is something known as councilman body or acidophil bodies. They are nothing but hepatocyte which have undergone apoptosis, and because it is an apoptosis, the cellular inflammatory response will not be there. So it is there nothing but apoptotic hepatocytes which are given the name councilman body or acidophil bodies. Then you have something known as mallorysilin, which is seen in alcoholic and non-alcoholic steatohepatitis. They are nothing but eosinophilic deposits of keratin. So this is the diagram showing ground glass hepatocytes. It is because of the diffuse granular nature of the cytoplasm in these hepatocytes, and the diagram which is marked as B, it is an immunoperoxidase stain for HPSAG from the same case, showing cytoplasmic inclusions of the viral particles. So here, as I mentioned before, acute hepatitis, it has a lot of acute inflammatory cells which are encroaching upon the portal area, portal triad, and you have ballooning degeneration with a lot of apoptotic bodies, and these apoptotic bodies are being removed by these macrophage aggregates. And as I mentioned, fatty change can be seen both in acute and chronic hepatitis, and the commonest cause for fatty change is the hepatitis C infection, and cholestasis, again it is one of the feature which is commonly seen in hepatitis secondary to hepatitis C viral infection. So this is a histopathological histological image showing acute viral hepatitis, where there is loss of lobular architecture and there are a lot of inflammatory cells in the sinusoids. So cells of acute inflammation are predominantly neutrophils. So there are a lot of inflammatory cells which are, along with good number of lymphocytes which are entering into the sinusoids, and the arrow head, and the arrow is showing the hepatocyte which has undergone apoptosis. Coming to chronic hepatitis. So, when you know that when any chronic form of injury, the hallmark is the inflammatory cell infiltrate. You know the cells of chronic inflammation are lymphocytes, macrophages and plasma cells. Similarly, here also in chronic hepatitis you get these cells in the parenchyma. And surprisingly, if it is not accompanied by a fibrotic change or a lot of fibrous tissue deposition, the architecture is relatively well preserved, and lymphoid cells being the cell of chronic inflammation, you get a lot of lymphoid aggregates. In case of chronic hepatitis, steatosis, interface hepatitis and bridging necrosis, they are seen both in acute and chronic conditions. So, this is something that we have noticed, but the hallmark of chronic hepatitis is deposition of fibrous tissue. Deposition of fibrous tissue is the hallmark of chronic hepatitis. So, if there is a continuous loss of hepatocyte along with extensive areas of fibrosis and fibrous tissue deposition, it will go for cirrhosis. And this is the diagram of chronic hepatitis. You can see the chronic inflammatory infiltrates are seen in the portal areas with bridging necrosis and fibrosis. Fibrosis being the hallmark of chronic condition. Then you have ground glass cells, which is a feature of chronic hepatitis B viral infection. Apoptotic debris, they are seen in both acute and chronic. You see fatty chain, which is again a feature of hepatitis C viral infection. Then if the insult is very massive, if the hepatic injury is very massive, the hepatic insufficiency can progress so rapidly that the time frame between the onset of symptoms to hepatic encephalopathy is around 2 to 3 weeks. So, it can be so massive liver tissue damage that it can go for hepatic encephalopathy within 2 to 3 weeks. So, in the entire liver may be involved, or random areas of liver can be involved in case of hepatic failure. The liver gets shrunken to such an extent that it can weigh just 500 to 700 gram, or around just 1/3 of its normal weight. So, on microscopy we see the reticular network is collapsed, there is extensive loss of hepatocytes, portal tracts are surprisingly well preserved, and because of the massive nature or the overwhelming insult of the hepatic parenchyma, the inflammatory response can be surprisingly very minimal. So, but if the individual or if the hepatic tissue is lucky enough to withstand the insult or the injury, and if it somehow survives for 1 week, then there is a replication of residual hepatocytes, and at the same time there is proliferation and differentiation of quiescent stem cells in canals of herring. These quiescent stem cells are known as the oval cells. They can proliferate and mature into both hepatocyte and bile duct cells. So, these cells play a major role in regeneration of the hepatic parenchyma. For this, the parenchymal framework is very important. If the parenchymal framework is preserved, regeneration can completely restore the liver architecture, but with massive destruction of the confluent lobules, regeneration will be disorderly, leading on to nodular masses. So, it will not be a uniform organized regeneration, they will give rise to nodular masses of liver cells that will eventually give a very irregular liver after the healing process is complete. So, if the nodular masses, if these nodular masses are more in number and with extensive areas of fibrosis, that will give, eventually manifest itself in the form of cirrhosis. So, if the fulminant hepatic, in case of fulminant hepatitis or fulminant hepatic failure, you should identify the underlying cause and treat it immediately. Otherwise, the only hope in such cases will be a liver transplant. Coming to the complications, so complications, one, there is hepatitis. If it is not taken care of immediately, there are a lot of hepatocyte necrosis. So, a lot of hepatocyte loss will be there. It can go for chronicity. It can be chronic active hepatitis or just a slowly progressing chronic hepatitis without no obvious symptoms or clinical manifestations. They can, some of them eventually lead on to cirrhosis. If there is a massive hepatocyte damage, they can go for hepatic failure, and in very unfortunate cases, they can go for hepatocellular carcinoma. Just a brief introduction to the kind of investigations that we do in hepatitis. Usually do a liver function test, which you will be familiar. Then if you are suspecting a viral etiology, you do a hepatitis viral panel. So, kind of getting the proper history, kind of exposure that the patient might have had. You just roughly assess what might be the etiological agent and order for hepatitis viral panel accordingly. You can do an ultrasound, and in rare conditions you can go for liver biopsy to rule out other causes of hepatitis. Then for a comprehensive metabolic panel assay, you do glucose level estimation, calcium level estimation, and electrolyte level estimation. So that was about hepatitis.